Welcome to everyone who's joining us tonight. On behalf of the AHPBA, my name is Tim Pollock, and I have the privilege of being the president of the AHPBA this year. We've been purposeful in trying to do different events during the course of this year virtually, given the obvious pandemic and our inability to be together. Some of our webinars have focused more on COVID-19 issues, but tonight we're going to focus on clinical HPB surgery. And I'm really delighted that we have an amazing group of experts who are joining us tonight to go over a number of different cases. We'll be starting off with a case around advanced colorectal liver metastasis that will be moderated by Dr. Hernandez from the University of Rochester. And then we'll follow up with the discussion of a case around locally advanced pancreatic cancer that will be moderated by Dr. Ferroni from the Massachusetts General Hospital. And then conclude the evening with a case presentation around incidental gallbladder cancer that will be moderated by Dr. Meitel from Emory University. I do want to remind everyone that the leadership of the AHPBA made a decision to move our meeting from March to August of next year. And our meeting will be held August 2nd through 5th of 2021 in Miami, obviously pending any unforeseen occurrences with the pandemic. And I also want to draw your attention to a new day pattern, and the meeting will be run from Monday to Thursday of that week. And we truly hope by next year that all of us will be in a better place, and we anticipate having an in-person meeting that will be safe, socially distanced, and allow us once again to all come together as an association. So with that, I'll turn it over to the first moderator. Roberto, thank you so much. I'm interested to hear about colorectal liver metastasis in this wonderful case you're about to share with us.
Thank you, Tim. Thank you very much for the introduction, Dr. Pollock. And so today I'm going to be sharing a case. We have as panelist Dr. Sefide Golami. She's a phenomenal surgical oncologist. She was training at Memorial Sloan Kettering Center. She's at UC Davis right now. She runs trials on hepatic artery infusion and a lot of interest in HPV. Our second panelist is going to be Dr. Shimul Shah. Everybody knows him from the University of Cincinnati, transplant and hepatobiliary surgeon as well. He was training in University of Toronto with a lot of clinical knowledge in this area. And everybody knows Dr. Will Chapman, our third panelist. Dr. Will Chapman, Chief of Division of General Surgery and Chief of the Section of Transplant Surgery at WashU and past president of AHPBA. With this, I'm going to start. I'm going to share my screen and can everybody see the screen? I just want to be sure.
Yes.
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 Okay. So let's stay on time. I will be presenting the case. We'll make some stops and we ask questions to the panelists. And please try the panelists to be clear, go to the point so we can create a good participation and we do not delay the following presentations. So this is a liver metastasis case. Let's start with this. This is a patient, 35 years old, extremely healthy patient with a very low BMI. Not commonly seen nowadays. Patient has a rectal sigmoid adenocarcinoma. It's non-obstructive. In the imaging, they were able to see that there were some enlarged lymph nodes in the mesocolon close to the primary tumor. And the patient has 6 small liver mets in the right side. No evidence in imaging of extrahepatic disease. At that moment, the CEA was 89, and in the biopsy of this tumor, they were able to test it for genetics, and there's no mutation. It's a wild type, BRAF and KRAS. So the team who saw this patient, they decided to go and say, all right, let's give chemotherapy, 6 cycles of FOLFOX, kind of very common that we see nowadays. And the patient has a partial response in liver and primary, and we can see that biochemically the patient had decreased in the CEA. So I hope at this moment there's no question for our panelists. So this is a short video that I have where you can see the liver, and we can see some metastases in the upper part of the right side, other one there in the right side, close to the right hepatic vein, in the periphery as well, close to the right portal vein, and in the left and in the right side, all of them in the right side. So with this, I want to ask a question to our panelists. What would be the plan? So what would be your plan? Let me start with Dr. Golami. What would be your plan in this patient who had colorectal metastasis, responded to chemotherapy in the right side?
I think given that you have multiple lesions that are small with a kind of high disease burden, I would actually start with an MRI with an EOBUS to really ensure that you have thoroughly studied her before and then assess what you have. I also would make one comment that in general, I think there is good trial data and support that, with TRIBE 1 and 2, that I would have actually treated a little more aggressively with chemotherapy using actually a triplet FOLFOXIRI versus just the FOLFOX. I think you get more bang for your bucks right away to be more aggressive. That would be my initial approach. And then after the MRI, I'm planning to operate for resectability.
All right. Dr. Chapman, would you do any MRIs in this patient who has a low BMI, no fatty liver, with a CT scan showing liver metastasis in the right side, and who responded to chemotherapy?
Yeah, I tend to agree with Sep. We get an MR in every patient. I think our radiologists feel the sensitivity is a little better. If there's disease in the left, it totally changes the story here. And you got to be concerned about synchronous disease in somebody like this. And so I would do that. I don't have a differing opinion of Sep otherwise. I think, as I heard you, she's going to require a left hepatectomy or left low anterior resection. I think the next question is going to be, let's assume there's nothing else in the left. Are you going to do a right hepatectomy and a left or low anterior resection in the same case, young, healthy patient maybe? I'd say we've kind of migrated to doing those separately, but those would be the next steps, assuming staging shows no other disease.
Okay, so let's go to the next slide. So the team decided to take this patient to the operating room. They decided to do a simultaneous colon and right hepatectomy for this patient, knowing that there was only disease in the right side and a primary responding. The colorectal team started, no concerns, did the left colectomy at T3N1. And the liver surgeon, when he came in and he did intraoperative ultrasound, exactly what you were mentioning, there was evidence of 2 metastases in the ultrasound in the left side. They were non-superficial, and they discovered this. So now what we're going to do, this is an MRI that we want to show of what they saw after they saw this patient with disease in the left side. And you can see there's a metastasis there in the left side that was superficial, and there was another one a little bit deeper. So Dr. Shah, what would you do now with this patient that has disease in the left side?
Because it's synchronous, the biology isn't great. I think that we wouldn't do anything with the liver. But let me just ask you, how did you guys decide who went first? The colon team or the liver team? Tell me about that algorithm.
So we're talking about this patient that is from outside their patient. And I think the decision from this team was that they will do simultaneously. What would be your opinion?
No,
What would you do first? Would you
No,
do
in the operating room, I've gone both ways. I just I like Will. I don't like doing them simultaneously, and I think we've talked about this online on social media. I've been burned a couple times with some bad cases, and in a couple cases I've gone first. Big operation, then you leave the room. The colon surgeon comes in and takes even longer to take the colon out, and you do get changes. So I do prefer for the colorectal team, I think, if I'm going to do it simultaneously, to go first, but I haven't done a simultaneous resection in a few years now because we've stopped doing them. We've kind of gone away from it. I know there's a lot of thoughts on that, but with the lesions you have on the left side, I don't think I would do anything. It looked like you could potentially consider a 2-stage there and do a left lateral right there and take those 2 lesions out on the left and then give more chemo and see what happens down the road. But personally, because it's synchronous, I would leave it alone and close.
All right. Sefide, what are your thoughts in this patient now that you saw that there's metastasis in the left side?
Knowing that, I think with the one superficial and one deeper, I actually would treat the left side. At the time, I think that's safe to do with 2 simple lesions, a small partial resection, wedge resection, and I would actually ablate the deeper lesion. Couldn't exactly see where it was, but I think that seemed reasonable. And then to do it essentially target in a 2-stage and then deal with the right side later.
Okay, well, so the decision in this case was similar to Dr. Shah make a comment. They decided to close. They thought this was not going to be working if they thought there could be more lesions that they couldn't see. And then they did that MRI that I shared, and they decided to send the patient for more chemotherapy to have more control of the disease. And they went for FOLFIRI for 12 cycles and reassessed in the meantime after a few cycles. And they added Avastin. The medical oncologist decided to add Avastin over the next 6 cycles. 6 months later, in this patient, after treatment, the CEA is now 8. The CT scan and MRI, now they learn and they are doing more MRIs, and they did an MRI. There's no lesions that they could see in the left side anymore, and only 2 lesions in the right side. I'm asking, what would be your opinion, Sefide, on doing a PET scan in this patient nowadays, in this case?
Yeah, I think there's really not. So in a resectable patient, we know from actually clinical trials from Canada that a PET scan does not really change necessarily the management. I think the change was about 8%. In general, if I'm really concerned about peritoneal disease, I think that's the only time for colorectal biology it's proven to make a difference in a management. So in this selected case, you could, but I honestly, in general, I don't get a PET scan for metastatic lesions that are only confined to the liver. BRAF patients are slightly different because they have a higher tendency for peritoneal disease.
All right, so this is a CT scan that they did, and clearly there's disappearing liver metastases. So we cannot see them there. What would you do, Dr. Chapman?
Is that MR? Is this a CT or an MR?
This is a CT scan.
So I'd get an MR, but let's assume there's 2 sites. I'd be cautious about charging back in, especially if the patient's had a good response. I think you could try to ablate those directly. You could laparoscopically ablate those, but then you're going to have to kind of wait and see.
But you cannot see them. Why would you ablate?
Well, you said there were 2 visible on the right.
Right.
Yeah, if you can't see them, if they're totally disappeared, there's nothing to do. If there are 2 that you can find, you could try to ablate them. I'll tell you, when we've seen visible sites under 1 centimeter, they are very difficult, at least for us, to find. They become soft, they're not palpable, and they're hard to see with ultrasound, even with the ultrasonographer helping us in the room. So the under a 0.5 centimeter, we would tend to wait and watch and see what happens. Is kind of the next step.
Okay, so this patient appeared to be responding, if everybody agreed with this, despite they were able to see more lesions in the initial scans. The team decided to do a PET scan in this patient that I'm sharing with you this short video. The CEA was coming down. You can see a calcified lesion in the periphery of the right side, and you can see that PET-avid lesion close to the right portal vein. And other than that, there's nothing more. Remember that this patient already had the primary removed as well many months ago. No more. What would you do now, Dr. Shah, that you can see a single lesion calcified in the periphery, not PET-avid? You can see as another lesion that is PET-avid in the right side, perhaps 1 to 1.5 centimeters. No evidence of other lesions in cross-sectional imaging. The patient is asking you, what else? What's next?
So I think this is an important conversation you need to have with your oncologist, because if the oncologist is just going to continue chemotherapy, I would argue that potentially just ablating that lesion that you can see that's PET-avid, how's that really going to change anything? You can easily do that percutaneously and ablate it if you want, but the patient's going to stay on chemotherapy because those ghost mets that you have are going to come back down the road, and no oncologist is going to stop therapy. So you got to determine what the long-term plan is going to be. And I would just continue chemotherapy, maybe do a percutaneous ablation of that lesion, since I don't do much ablation, and continue to monitor.
Dr. Golami, would you?
There is an advantage here, though, of taking out that left lateral at the time of the colon resection. You can see the advantage because those mets disappeared, and then you can always come back now with the liver regenerated and do it right.
Right. Dr. Golami, you agree to give more chemo to this patient at this moment? Or would you take it to the OR or ablation, as Dr. Shah mentioned?
I really think we've already given way too much chemo to this patient. I think to one point to make, the reason I wanted to treat it initially, it's exactly for this particular program. We know that disappearing liver mets for lesions that are under 2 centimeters are very likely, especially when you're giving this much chemo. For smaller lesions that before any treatment, before a chemo, I actually do fiducials here because I think that's a safe way at least to have a target for for later treatment. And yes, I would definitely treat this. I think you can make an argument that the patient could go on a chemo holiday if there's really no evidence of anything else after a long course of chemo. Again, that's a discussion, but I would treat. I would not just keep giving chemotherapy with what end goal, really.
What about this patient hasn't shown any evidence of extrahepatic disease? I know you were trained in a place where hepatic artery infusion is very common. Would you consider this patient for that?
Yeah, I think we can discuss hepatic artery infusion, but at the beginning, I wouldn't do it now. I think that there's a discussion that should have been at the beginning, where you have essentially bilateral disease with biliver mets and a really young patient that you know is an aggressive disease to begin with synchronous. I think that's definitely something I would have discussed at the beginning of the case with the patient, with potentially even clearing her left side.
So Sep, would you have put a pump in that colon case if you were in there?
Yeah, so I think I wouldn't do a pump and a left colon and everything all together. We try here, since we've started a new program, I'm trying not to do colons with the pump just for lowering the infection rates. It certainly can be done. That's how we did it in training. We would put a pump in, clear the left side, and can then do a simultaneous colon.
All right, let's move on. So as Dr. Shah mentioned, they were worried, the tumor board, about having more ghost lesions that were going to come back. And according to the literature, I think around 70% normally come back. However, this is retrospective. They wanted to keep some break of chemotherapy, but they said, let's give oral capecitabine plus Avastin, and they give 8 more treatments to this patient. We have to see that now this patient has 2 years post treatment since the diagnosis, with many multiple treatments. And this patient shows the small lesion, smaller now, and patient has been very stable with very low CEA. And just 1 lesion that is PET-avid and even smaller than before after oral chemotherapy with the capecitabine. So concluding, this is a one calcified lesion in the right side, a PET scan showing just a single avid lesions in the right side, CEA is 5, 2 years post-chemotherapy. Now, what would you do, Dr. Chapman?
I would go after the single lesion. You're saying single lesion on the right side, 2 years into it.
Correct.
Yeah, I would go after it. I try to do it percutaneously or laparoscopically, because I think there's going to be more to deal with.
So you're talking about doing you're saying going to that lesion through interventional radiology, or you're saying as a resection?
No, I'm thinking about this is, how big was the lesion?
It's around 1.5 centimeters.
Yeah, either probably percutaneously by our IR guys. If they can't target it, and sometimes they can't, depending on where it is, we have a little more flexibility in terms of targeting. And a minimally invasive is fine. And so there's some center variation and, you know, who's doing those, but that's what I would try to do. Where is it on your scan? So there's a microwave plus SBRT. I think that would be fine.
So I think they listened to you and they decided to go for it. And they did a microwave ablation. You can see the area there close to the calcified. And they also give SBRT to this patient. And the patient, they also hear Dr. Golami's suggestion saying no chemotherapy. So they give a vacation, a break of 4 months. And after that, they have this MRI. And this is what it's showing. We can see the liver pretty enlarged. If you can see some dilation of bile ducts in the left side, you can see the area where it was ablated. We'll see it again. And then there's this lesion here in front, just adjacent to the area of ablation. A new lesion just beside the area of ablation. Other than that, there's nothing more. And
so one thing, and somebody asked a question, and I think it's a good one. You know, why SBRT? If you had an adequate ablation, and you're talking about a 1 centimeter tumor, 1.5, it ought to be able to be well ablated. I wouldn't add radiation to that. You know, if you can't deal with it definitively, SBRT is a reasonable consideration, but so are other things like, you know, Y90. But those are not going to be curative. Right now, you're still at the potentially curative stage, to me.
Right. Okay. Dr. Shan, so now this patient has ablation, lots of chemotherapy, SBRT, and we can see if we can call it recurrence or residual disease in the right side just beside that. What would you do now for this patient?
Ablate it again.
All right.
Keep going at it. Keep chipping away. That's all you can do right now.
All right. Oncology decided to ablate the patient. Surgeons didn't say we don't want to do surgery. There was some dilation of the bile ducts, as you saw before. And they did ablation to this patient.
The reason why ablation makes sense here is this looks like a local recurrence. I didn't get a good look at the scan, but it looks like a local recurrence. It doesn't look like a new spot on the left side or somewhere far away. So I would just make sure you have local control. That's the key.
And the patient has been continuing chemotherapy. They restarted FOLFIRI because of that residual recurrence disease. Tolerating very well FOLFIRI, the patient. CEA is 4, no evidence of extrahepatic disease. And this is what we can see in the CT scans 4 months later after restarting the chemotherapy. A liver, which it's enlarged, bile ducts dilated, the ablation area, the new ablation area, perhaps some, they did a PET scan. And in the PET scan, they are able to see the same lesion that we saw looks smaller. And they see now a questionable lesion inside of the colon in the left side, However, the nuclear medicine team said this might be just residual in the GI. They suggested to do a colonoscopy. The colonoscopy was performed. There's normal colon, no tumors. The CEA is 4. Platelets of this patient is 72. Bilirubin is high, 2.3. This patient has been on multiple treatments for many, many months, years, more close to 2 years. The alkaline phosphatase increasing, and liver enzymes slightly elevated in the 100s. And now the patient comes with Dr. Golani, and he's coming, and the husband is asking, hey, I want a hepatic artery infusion. I want something. Would you do resection? Or you do a hepatic artery and followed by resection. I want to live longer. I'm not tolerating chemo anymore. I've been on this for too much time. What are my options now? What can you do for me?
I think this is a really great example of prolonging chemotherapy and not thinking of a definitive resection plan, honestly, to begin with. Your platelet count and thrombocytopenia is most likely from this oxaliplatin splenic sequestration that you've had for prolonged treatment for almost 2 years. With those bilirubin numbers and your platelets and everything, I think a pump, to put in as like a third line is also not really ideal. So any of those things I think should have been done way earlier. A resection also with a platelet count of 70 is also not ideal. So you're sort of limited. And I think you've just kind of gotten yourself into this treatment where you don't have a lot of options.
Dr. Shah?
I was going to ask Sep, would you agree the pump is out because you already got biliary disease, right? I think that's what you're saying.
Yeah, I don't think now, honestly, that's my point. I think it's too late, and you don't want to hurt this patient by increasing more biliary toxicity.
Roberto, I think an ERCP or some assessment of why there's biliary ductal dilatation is something that ought to be entertained. You could do a liver biopsy. I'm concerned about that bilirubin at 2.7. That's would be a major concern. At some point, 30-year-old patient, very minimal disease, running out of other options. Would you think about liver transplant?
So a biopsy was done, Will, as you alluded, and the biopsy clearly showed damage from chemotherapy. There's no biliary obstruction by itself. It's just biliary damage in this patient through prolonged chemotherapy, plus the ablations and the Sbrt.
Was there fibrosis or anything in the liver?
Yeah, there was fibrosis, stage 2 of this liver. So Dr. Chapman mentioned about liver transplantation. Shimul, any thoughts about it? You have done liver transplant for colorectal metastasis, am I right?
Yes, we have done 2. We just did one on Saturday, our second case. It's very select cases. We don't know what the long-term results are going to be. Both of mine were 5 years of isolated liver disease. This is only 2 years, I think, Roberto, maybe 3 now. But
2.5.
But it is liver-only disease. We have a whole protocol in place, and this would probably fit the criteria, especially now that you have liver disease going on in the liver, but you have isolated liver metastasis, and you're running out of options in a young patient.
We have done 3, and I would echo the points that Shimul has raised. I think it's got to be very selective. The Norway group has published small series, 20 patients, but showing pretty favorable results, similar to transplant for other indications when the highly selective cases are transplanted.
So we're gonna have to have our esteemed past president, Dr. Chapman, have the last word because we're at our time for this portion of the webinar. I do want to thank Dr. Hernandez and our panel. That was a great discussion about a very, very interesting case. So with that, we'll move on to Dr. Ferroni, who will be moderating a case that we'll be discussing locally advanced pancreatic cancer.
All right, thank you. I will stop sharing my screen.
Thank you. Thank you, Roberta.
Good afternoon. It is my great honor to be here. So thank you, Dr. Pollack, for the invitation. And I'd like to introduce our panelists. Dr. Marco Del Chiaro, who trained at the University of Pisa and then spent approximately 10 years at the Karolinska, and now is professor of surgery at the University of Colorado. Jin He, who went to medical school in Beijing and then did his residency and fellowship at Johns Hopkins, where he is the Paul Newman Professor of Surgery. And third, but definitely not least, and since I did this in alphabetical order, Alice Way, who trained in Toronto and spent over 10 years of her early career at the University of Toronto and is now at Memorial Sloan Kettering Cancer Center. And so we'll get started. So the case is of a lovely 47-year-old woman who has no past medical or surgical history, who presented with epigastric pain and jaundice. She works as a teacher. She's a non-smoker. She has no family history. She had scans performed, and her initial CA19-9 with a normal bilirubin was 860. So I have some cuts from the scan from the arterial, venous, and a coronal view. And as you can see, there is involvement of the SMA for a fairly long segment, as well as complete occlusion of the SMV portal vein junction. And so what I thought I would start with in asking our panelists is, in a patient like this who has an EUS and a biopsy and has this type of profile with no mutations, what kind of chemotherapy are you thinking about, and how many cycles do you start with? And I thought we'd go in alphabetical order and start with Professor Del Chiaro.
Marco, you're muted.
Yeah, so thank you very much, Christina and team, for the kind invitation. Well, let's say that I believe regarding laparoscopy, no, we don't generally use laparoscopy staging, at least at this point, but generally we don't. I will generally, you show me what you did. But
Sorry.
I agree. I will definitely start with FOLFIRINOX. This is a young patient, fit, apparently. We know that not always, but majority of cases benefit from FOLFIRINOX more than from other kind of treatment. How long is a very good question, actually. And I think we have not even robust data how long it should be. Generally, we use the same criteria. You use it. I already saw your answer, but let's say 8 cycle. Sometimes the tendency is also, especially if the patient doesn't tolerate completely well the treatment, being a little bit shorter and then complete the other part of chemotherapy after surgery. So it changes a little bit even according with the patient. But I would say no laparoscopy, FOLFIRINOX, as long as possible, let's say 6, 8, and then eventually aspiration.
Professor He, at Hopkins, what would you do with this lovely lady?
Yeah, I would agree with Marco that in general, for young, healthy female patient with locally advanced pancreatic cancer, we will favor to start FOLFIRINOX. We typically don't perform diagnostic laparoscopy unless the imaging is showing potential carcinomatosis. We just need another procedure to confirm it. So regarding the how many cycles, I would say, 8 cycles in general. That's based on some retrospective data showing 4 months of chemotherapy was correlated with a better outcome. But in general, as long as the patient is responding to the chemotherapy, we want to continue the chemotherapy and maximize the benefit of the chemotherapy.
Professor Way at Sloan Kettering?
Well, I would say that I think we all agree that FOLFIRINOX, when patients are fit, is our preferred approach. I would say that, this case is easy. The patient's locally advanced, so the patient likely will have quite a bit of chemotherapy. I would argue it's not so clear how much chemotherapy patients should have because the evidence is not so clear. And certainly the trials to date haven't really been done with 8 cycles. So, I think that I would start with 4 cycles, restage. In this situation, probably the patient's not going to respond to much in that. And the median amount of time that our patients who've had neoadjuvant FOLFIRINOX have had is 8 cycles, but I think it's more empiric than data-driven at this time. So I remain open-minded. I'd say the best reason to give more chemotherapy is so that if they're not well after surgery, or that perhaps they don't need any post-operative adjuvant. So maybe I can turn the question to you and say, what about post-op adjuvant chemotherapy?
Yeah, we're going to get to that
All
point
right.
at the end of the discussion, but I wanted to bring up 2 other points. So in a patient, if you had done laparoscopy, as Jen mentioned, because you had some concern and you saw minimal micrometastatic disease in the liver, would you sort of equivocally not offer that patient an operation in the future, or would you consider an operation in the future for that patient? And then the second part of that question is, if after 4 cycles you were to get blood work and a scan, what would trigger a switch in chemotherapy, or is there no trigger to switch chemotherapy? And I thought we could start with Jen.
Yeah, great question, Christina. So that is going to the question about definition of oligo liver metastasis. That's a very complex question. So it depends on your definition. If we see miliary liver lesion all over, there's no chance we're going to offer the patient surgery in the future. If we see 1 or 2 or less than 3, potentially resectable lesion in the liver, confirmed by MRI, PET-CT, and they responded to chemotherapy, I won't stop considering surgery in the future if they responded. Now, regarding when do you switch chemotherapy, that's a tough question. We typically, based on imaging response, not based on the CA19-9 response. So that's saying that, if imaging showed tumor progression, invading more vessels, and obviously CA19-9 is going high, that's an easy, a direction to follow, switch chemo. If imaging shows progression, CA19-9 is not, responding or decrease, that's a tough situation, but still we'll consider switching chemo. But again, that's sort of like institutional dependent, choice.
Alice, what about you?
Well, I mean, I think particularly, at this time, the role of planned liver resection for oligometastatic pancreas cancer probably should be in the role of studies. So I don't object to it from a protocolized approach. I'm not sure that I would advocate it as a forward planning approach that will give you some chemo and then we'll do some liver surgery, we'll do some, Whipple surgery on you for your metastases. But I think for patients with a very durable response that is, outside our typical framework, we would certainly consider salvage liver resection for these patients, but it's not a very common situation that you come across. I will say it's happening more and more now, and I do think this is a very live question that really is perfect for studying. In terms of the issue of switching chemotherapy, I'm very much in agreement with what Jen recommended. I do think, though, if patients have a very high CA19-9 that doesn't come down after any biliary obstruction has been treated, even if the tumor looks about the same, I would consider switching a little bit earlier in that situation, though thinking about the patient's entire journey, like the chemo they get now, the chemo they may require in the future is something that I would often factor in the equation. So if they have clear progression, particularly radiologically in tandem with CA19-9 tumor markers, I would switch. If it's one or the other, I think it would be a considered approach depending on how they're tolerating it and whether there's a plan for surgery.
Great. And Marco?
Yes. So let's say that, first of all, metastatic pancreatic cancer is not a surgical disease. The question here is that we know that basically every pancreatic cancer is a metastatic disease, even when we don't see metastasis. So clearly the question here is becoming interesting because you see a single one, very small, you treat the patient 1 year with chemotherapy, does very well, CA19-9 come back to normality. The patient is very young and very motivated. Yes, every one of us sometimes does. I don't think we have really data on that. We have retrospective data. We have no comparison group because maybe the same patient doing only chemo have the same survival. So I think it's a very intriguing question. So the answer is yes, in very, very, very selective cases without any evidence. I think every one of us did sometime. I believe we need to start to evaluate that in prospective randomized trial because I am not sure that some great results every one of us saw are related to the surgery or instead to the very excellent biological response of the tumor. Regarding shifting chemotherapy, I think for me, whenever there is not a radiological progression, I don't care about radiology. Could be complete pathological response and see the tumor exactly as the beginning. So I think radiology, or there is progression or you cannot state response. CA99 generally is a good indicator when it's elevated at the beginning. So seeing the CA99 going down is a very good prognostic factor. Going up is a bad prognostic factor, or remaining stable. And there probably when we shift chemotherapy as well as when radiology may show a progression of disease, but not stability of disease. I don't think is enough to say that there is no response.
Great. Well, I already gave it away. So she did get 8 cycles of FOLFIRINOX, because she's nice and young. She tolerated it very well, and her CA19-9 decreased to 78. And here is her imaging, and what you can see is that she still has superior mesenteric artery involvement based on the scan, but her SNV portal vein opened up very nicely. And this is, of course, always, you know, what we hope to see when these patients are getting neoadjuvant therapy. But at this juncture, you know, what do we think in someone who still has arterial involvement, however, the vein has opened up? Alice, would you consider radiation at this time? Or would you consider resection at this time? Or would you say more chemotherapy because she's tolerated 8 cycles so well?
You know, I do favor preoperative radiation for patients with locally advanced disease as a way to try to sterilize the margins. I don't think it necessarily changes the approach, the surgical approach that you may need. So if you plan an arterial resection, you may need to still do it after radiation. But I would favor radiation at this time rather than further chemotherapy.
Marco?
I will not, and I know that saying that in America is complicated. I will not use radiation in those kind of patients. Actually, I have nothing against radiation in borderline vein involvement, but I would never do never. Let's say I will not prefer to use in patients with arterial potential involvement. The reason is that I believe we have a pretty solid data showing that radiation doesn't increase survival in pancreatic cancer, or at least we don't have data showing that increased survival in pancreatic cancer. And I think potentially when you need to go around an artery, and here, you know, I'm not a believer or not believer in arterial resection. I think arterial resection need to be done in very, 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 very selected cases if needed. But today we show that divestment is possible in a large percentage of patients in which the artery seems to be involved at the CT scan, but after neoadjuvant, you see that the tumor come out pretty nicely from the artery. But this operation is not less dangerous, in my opinion, or complex than an arterial resection. So having a vessel irradiated and doing a complete divestment of the vessel will make me very nervous. So me too, I don't have evidence that this is a risk. But let's say I have some experience, some personal experience, and actually I think makes sense. You irradiated tissue, you are going in one of the, let's say, Achilles heels of pancreatic surgery, which is potential arterial bleeding after surgery for erosive bleeding. I would not use radiation, especially not knowing that there is a real advantage for the patient.
So Jin, can you comment on what you would do? And I guess one component that we haven't addressed yet is in someone where the SMV portal vein opens up with neoadjuvant chemotherapy, do we still consider resection of that segment of vein with the presumption that there's still some live tumor cells there, or do we assume that it has been somewhat sterilized? In addition to answering the question about radiation and potential arterial resection.
Yeah, let me just quickly follow Marco's comment. I think for this patient, clearly showed great response to the chemotherapy. My principle is if chemotherapy is effective, just keep it going. Now, regarding the, whether the vein need to be preserved or resected after significant response to the chemotherapy, my general principle is if the vein can be preserved, I'll preserve the vein. I don't assume there's still some, tumor tissue around the vein, because I think the chemo is clearly very effective in this case. Now, radiation, there's no data to support radiation. Even Alliance data right now is, pending. It's probably going to be negative. But in our daily practice, we typically will offer radiation when we see arterial involvement, try to achieve a negative margin. But I do agree there's a potential increased risk if we do divestment along the artery. So I'm still struggling to make a decision whether radiation or not. That's my just bias here.
I mean, I would say as surgeons that we talk about radiation like it's all the same thing, but I do actually think it's far more sophisticated than we have let on. There is some data, the randomized trial from Korea did actually have radiation, was chemo radiation in the borderline resectable. So that's randomized data that was stopped early for effectiveness. So I do think there is some data. I think also if you look at the Alliance trial where the radiation arm was stopped for futility, that was Sbrt. We could have a very long conversation about whether Sbrt is equivalent to 50.4 gray of external beam radiation, whether it's equivalent to higher dose, ablative dose radiation. So I do think we need to be careful that even though old data, LAP07 I'm seeing on the chat was negative, LAP07 is like an antiquated treatment where patients actually progressed before they got randomized to radiation. So I do think we have to keep analyzing radiation data in light of new data. So LAP07 was gemtarceva, that is ancient. And so readdressing radiation in FOLFIRINOX era, I think is important. So I think there isn't great data, but that doesn't mean it's not effective. It means that perhaps we haven't found the right combination yet, or lumping a bunch of stuff together.
I think those are all excellent points because we always struggle between 50.4 gray of photon radiation, which we tend to do for arterial involvement, versus Sbrt or short course versus protons and short course protons for patients who are borderline. So this patient got 50.4 gray of radiation with capecitabine, and the CA19-9 went down to 11 post-chemo radiation. And so here you can see the scans, and again, you can see the SMV portal vein open, but still continued arterial involvement. So per our protocol, we went to the OR and we did a laparoscopy with Whipple and then intraoperative radiation therapy with 10 gray. So I was hoping that you could all comment on laparoscopy after someone has had neoadjuvant therapy, whether there's any utility or when you use it in your practice, and whether or not intraoperative radiation therapy comes into play when resecting patients. And for this woman, I did an arterial divestment, and whether in that situation where you're worried about microscopically positive disease when you're not resecting the arterial vessels, whether you would consider intraoperative radiation therapy. So I thought maybe, Marco, I know that radiation is probably not what you're using, whether pre-op, post-op, or intra-op. But if you could comment on laparoscopy, and then we'll have Jen and Alice comment as well, please.
Well, I honestly, as I told you, it happens that I use laparoscopy sometime, but it should be because I have some extra suspicion for those patients. In general, I did for a while, and honestly, it was a very, very few cases in which laparoscopy changed the situation. So very difficult to find surprise nowadays. But of course, if there are some doubts, sometimes I use it. So I don't use routinely, sometimes I use. I don't use intraoperative radiation. And, you know, I believe you know, in locally advanced, I think there are two points. If you want to speak from a technical standpoint, vein, I think, is never a big issue. So my attitude is if the vein comes out nicely, I don't care. Sometimes I think it's easier to remove the vein and reconstruct than just to try to take it out the tumor from the vein. Very difficult from the artery. Vein is very well demonstrated, same morbidity and mortality, no really big issue. So I don't really care if I need to remove a vein or not. And this is sometime, again, in my opinion, make the operation easier. Regarding artery, I think I would have done like you did. I mean, I think maybe you are disappointed. Maybe you are expecting me advocating for arterial resection. I think if you do this kind of surgery, you need to be ready to do an arterial resection if needed, because sometimes it's needed by necessity. But I don't think that if you can divest, you should proceed by them. I mean, just as a principle to do an arterial resection. You need to select very well if you want to have good results, the arterial resection candidate. They should be very, very little number in your case. Otherwise, I think you are overusing. That's my personal view. Margin, you know, margin is something I'm probably very much different from the opinion of all the other. Microscopic margin, if you start tomorrow to use the European classification of margin, you will have 80% of your patient R1, even in primary resectable. And in fact, patients die for metastasis. It's very difficult that they die for local recurrence. So the problem of pancreas cancer, in my opinion, is biology. If you have a chemotherapy that really control biology, you can be aggressive as much as you want. If you don't have chemotherapy controlling biology, probably we should not operate even primary resectable. That's a little bit, you know, extreme comment, but just to make clear that as surgeon, we do something. We don't cure pancreatic cancer. It's a multimodal treatment. And if chemotherapy doesn't work, we cannot do so much. If it works, we can maybe do even more sometime.
Marco, I think you're going to put us all out of business if you keep talking like that. Alice?
Well, I was just listening to Marco's a comment about whether or not we should do any surgery at all. And I think that's a discussion maybe for another day. I don't use intraoperative radiation. And I think laparoscopy, I really find it doesn't make a big difference, particularly on the day of surgery for somebody who's had neoadjuvant therapy. I do think, for example, on study, or if you're going to just before you start neoadjuvant, particularly in a patient where they're, you know, MD Anderson type 2, whether you wondered if there's metastases or the CA19-9 is high, it may be helpful to confirm any suspicion of metastases, really for planning purposes.
Jin?
Yeah, I routinely use diagnostic laparoscopy on the day of major surgery for those patients after neoadjuvant chemo radiation, just to make sure I don't miss occult metastases. I know the incidence is very low, but still, that's just my routine. And we don't do intraop radiation, you know, not because, you know, data analysis, just because we don't have the capacity.
Yeah, so we've had a long history of intraoperative radiation therapy, and I see that Will Chapman asked about, you know, is there any benefit? So all of the data is retrospective. None of it is in a prospective trial. And if you look at the patients who have an R1 resection, who got intraoperative radiation therapy, and this is in the neoadjuvant FOLFIRINOX setting, it does seem to level the playing field, and they seem to act a little bit more like an R0 resection. It is statistically significant, but again, it is retrospective data with all of the issues with retrospective analyses. So I wanted to quickly show you what her pathology looked like. You can see that there's a 1.4 centimeter tumor. She does end up with negative margins. She has 24 nodes taken out, none of which are positive. And so now the question is in light of the PRODIGE trial, she's gotten 8 cycles of FOLFIRINOX preoperatively. would you in this setting with a CA19-9 of 11, negative nodes, 1.4 centimeter tumor with negative margins, give additional chemotherapy adjuvantly? She had no complications. So from that standpoint, she would be able to tolerate it.
Are you asking me?
How about we have Jen start? Sorry.
Yeah, my practice, for patient recover nicely from the surgery with no complication, I would favor this patient to finish a total of 6 months of chemotherapy. So she finished 8 cycles before. You know, I would say, you know, 4 more cycles just to complete the story.
What about you, Marco?
I agree.
Alice?
I think I would do exactly the same, especially at this age, especially in a patient that overcome the operation very well.
I would agree.
All right, great. So she presented originally in 2015. She was operated on in September of 2016. She just had a follow-up visit about a month ago. Her CA19-9 is still low, and her CT scan still shows no evidence of disease. And I thought I'd just quickly show you her CT scan, and you can see that I left plenty of clips during this arterial divestment. One last thing that I wanted to bring up, and I think Marco really highlighted this very well in terms of what kind of biology we're talking about and the biology of the disease. When we looked at the patterns of recurrence for our subset of patients, this pie graph is for the patients who present with upfront resectable disease and then get adjuvant therapy. This is the cohort of patients who got neoadjuvant chemotherapy, and this is borderline and locally advanced patients. And the majority got 6 to 8 cycles of FOLFIRINOX, depending on tolerance, then radiation, then resection. And then this last graph is the graph that is from our phase 2 clinical trial. And the reason I want to highlight this pie graph is mainly because clinical trial patients have a much more controlled follow-up period, unlike patients who are retrospectively studied. And this is for the site of first recurrence. And you can see here that for the local recurrence patients, 33% did, for the locally advanced patients, 33% did present with local recurrence as their first site of disease, which may give some data to support the role of radiation plus minus intraoperative radiation in terms of further trying to control the disease. And it may also point that to us trying to do maybe more arterial resections, assuming that we can keep the morbidity and mortality at an acceptable level. And I don't think having a mortality of 10, 12, 15% with arterial resections is acceptable. And obviously Marco Del Chiaro's results are incredible, and he has a mortality with arterial resections that he's published that is, you know, what we see for Whipple's normally, which is 2 to 3%.
Honestly, Christina, you know, I saw even some comments. I believe there are arterial resection and arterial resection. And I think sometimes I get some criticism of selection bias. I would not call selection bias. I think selection. So I think if you are very strict in your indication, you basically select very fit patient. You do reasonable arterial resection. What I mean is that you have a small tumor near to an artery and it doesn't come out. I mean, that's not a locally advanced. That's a tumor in an unlucky position. So probably biologically is different. But if you start to do arterial resection for everyone, necessarily you will have a high morbidity and mortality. Plus, my number are small compared to other series. So, you know, it's just enough that you have 2 more patients that die or doesn't go well, the number change very quickly. And the fact that they're small is because I try to be extremely selected in doing this kind of cases, because I think if you start to do to everyone, the results cannot be good. And, you know, so I believe selection and biology more than just, but in the other hand, I want to even say that a small tumor near to a vessel should not be an excuse to don't proceed with surgery if biologically you think the tumor deserves to be resected. So the story is valid from both sides. you need to use, I think, an approach that goes trying to go in the interest of the patient. No one of us knows if always we do, but at least we should not do, let's say, knowing that doesn't work. Let's put it this way.
So I think we'll have to conclude with the controversial topic of arterial resection for pancreatic cancer. And that was a great discussion. Thank you, Dr. Ferroni and the panel. I'll now like to turn things over to Dr. Maitel, who's going to be discussing incidental gallbladder cancer. Shisha?
Thank you.
Shisha, are you there? I can see your slide. I cannot hear you. I don't know if you're on mute.
Yeah, one second.
Oh, no problem. Now I can hear you. Yep.
Can you hear me?
Yes, I can hear
Okay,
you.
perfect. Can you see my slides?
Yes, I can see your
Okay,
slides.
For some reason, my Zoom thing disappeared. Okay, well, thank you. I just wanted to welcome everyone. And again, thank Tim for putting together this webinar and inviting me to participate in it. Also would like to very much thank you, my three panelists, and I'll introduce them very briefly, but thank you for agreeing to share your expertise on this topic. This topic is on incidental gallbladder cancer, so there won't be a lot of fancy pictures. This is going to be more of a disease discussion. But first, I'd like to introduce Professor Nicolas Habuffe from Santiago, Chile. He works at the Catholic University and in Santiago, and we're very excited to have him as he'll shed some light on how this disease is managed in South America, particularly in Chile, which is one of our epicenters of gallbladder cancer in the world. Then we have Rebecca Snyder. She did her undergrad at Princeton, did her medical school at, oh my God, I'm forgetting where he did medical school, but she did her training at Vanderbilt and then did her fellowship at MD Anderson and now is at East Carolina University and is working with a great surgeonic division there. And then finally, Sky Mayo, who did his MD and MPH at the Oregon Health Sciences University, is a true outdoorsman, went to across the country for Hopkins for his general surgery, then went to New York for his surgical oncology fellowship at Memorial Sloan Kettering, and then returned home at the Knight Cancer Institute at Oregon Health Sciences. So we have a great panel today. And basically, I'll run this very similar as we've been doing this, but again, this is going to be mostly kind of a disease discussion. There's not a lot of imaging to show, I think, for incidental gallbladder cancer. So in brief, we have a 59-year-old female who, with a history of just hypertension, so very healthy patient, presented with some right upper quadrant pain, had an ultrasound done at a community hospital, which showed a gallstone measuring 1.5 centimeters and some thickened gallbladder wall, went to the operating room, had a laparoscopic cholecystectomy done where they found a hard gallbladder, but they got it done and they brought it up, sent her home that same day. And the pathology report when she came back to her post-op visit was a well-differentiated adenocarcinoma. They did see positive lymphovascular invasion and positive perineural invasion. However, it was only a T2. They could not tell whether it was on the peritoneal side or the liver side. And the cystic duct margin was negative. So based on that information, I would like to kind of go, what are the next steps? So we'll start with Dr. Schneider. What are your thoughts in terms of how you approach these patients when they come to your office?
And so I would ask one other question about the pathology. Did you have any lymph nodes in this specimen or any information about Colo's node? So
no lymph nodes were taken out.
Okay. So, I mean, I think obviously at this point I would want to do some additional imaging. And so reviewing obviously the op note, depending a bit on the reliability of the surgeon who did the lap chole. But then I would start typically with the CT scan at this point to look for any evidence of distant disease.
Okay. And how often do you get that op note and how important do you think it is to get the pathology reviewed at East Carolina University from the community?
I think it's helpful. I mean, I think, you know, it's one thing if it's a general surgeon that you know well that's done the operation in your institution and that you can talk to about it. But obviously, you know, we've all had transfers of care from surgeons where we've not been able to discuss it directly. And then it's unclear from that op note or that communication whether there was any sort of systematic evaluation intraoperatively for peritoneal disease or hepatic disease. So I think that's important to keep in mind. Okay.
Dr. Mayo, if the op note says that the gallbladder was ruptured and there was bile spilling all over the place, how does that affect what you do? And do you pay attention to the gallbladder being retrieved in a bag or not? Or does that make really a difference in this disease?
Yeah, undoubtedly, I think it does. I'll also comment on the path review. I mean, just recently this year, we've had specimens reviewed here at our institution and actually found a positive lymph node that wasn't even mentioned in the outside review. So I think it's imperative to do that. In terms of the operative note, I make every effort I can to actually get a hold of the surgeon referring, because oftentimes these are templated lap choles and it's a templated op note, and they really won't make any real description of any biliary tract violation, rupture or decompressing with a needle cholecystostomy, all of that. So I think it's really important to know if bile was spilled during the operation.
Yeah. Dr. Harufe, how about you in Chile? How is the experience there of getting these from the community?
Hi, hello to everyone, and thank you very much for inviting me. So I agree with all the debaters. I think it's very important when we have a incidental gallbladder carcinoma to ask the surgeons, the original surgeons, how did they do the lab chole, if they took the gallbladder out with a bag, if there was any disruption of the gallbladder wall, and also ask the pathologist. And in this case, it's a very common case. This is a porcelain gallbladder with calcification in the wall. So it's a risk to have a gallbladder cancer, about 10% of the cases. So what we do in this case is to do a total etapification before going to surgery. And the best exam for that is PET scan. The PET scan is a very good examination for gallbladder carcinoma because it's a tumor with very high metabolisms. So we try to do a PET scan, and then if the PET scan there's not a lesion outside the gallbladder bed, we go straight to radical surgery in this case.
Okay. So there were some comments about, if the gallbladder perforated or if there was bile spillage, how would that change? And Dr. Mayo, you want to elaborate a little higher risk for peritoneal disease. So would that necessarily exclude you from an operative approach at some point, or you would just change the approach to how you do it?
I think I look a lot harder. I'll really want to, even consider, well, one, how long was from the time from the operation and the spillage to when the patient actually makes it to our office. I think that also has an influence. And, in general, we try to resect them and kind of, within 30, 40 days of their diagnosis or their operation. But I just look a lot harder if there's a biliary tract violation, and I'm looking for a reason to understand that I'm not going to likely get ahead of this with a localized operation, also depending upon the T stage of the cancer.
Right. So Dr. Snyder, Dr. Harufe mentioned a PET scan, but you mentioned that you would get a CT scan. So your thoughts on the optimal imaging and in your practice, is a PET scan necessary, or how do you use that?
I typically start with CT. I think, if there are some aortocaval or celiac nodes seen on CT that looks suspicious, then I would consider doing a PET. I think the role of PET has not been clearly demonstrated thus far. So I tend to use it selectively if there's something suspicious that I see on CT. Okay. So yeah, Dr. Harufe, I'd be curious, the PET scan, I would imagine you're using more for distant disease, because the PET scan, after a laparoscopic cholecystectomy, hard to evaluate in the gallbladder fossa and the porta hepatis, right? So I imagine you're using it for distant disease primarily?
Yes, because if there is some tumor or residual tumor in the gallbladder fossa, it doesn't preclude the next operation. So doesn't matter if there is something there, or you can find even inflammatory disease in the gallbladder fossa, which also have some demarcation in the PT scan. But that doesn't matter. That doesn't preclude the radical surgery, only if you find metastatic disease.
Yeah. Okay. Now, the staging laparoscopy, we often talk about we just talked about staging laparoscopy for the pancreas cancer, but I think it's also applicable for gallbladder cancer, which probably does not have that much of a different outcome for many patients. But Dr. Harufe, do you ever use staging laparoscopy as a separate procedure, or do you always start with a staging laparoscopy prior to re-resection?
All the time. This is mandatory.
Mandatory.
Gallbladder carcinoma. This tumor is very, the tumor like the peritoneum. So you have to do a staging laparoscopy. Remember that this is incidental cancer. So the patient had a previous lap chole. So it's not a big issue to redo a laparoscopy. And nowadays we're doing all the radical surgery by laparoscopy. So we start with lap all the time.
Okay. All right. But you would, Dr. Snyder, is there ever a time where you do a separate staging laparoscopy, like scheduled only for 30 minutes in the operating room that day?
Yeah, I think so. I mean, I think especially if you have T3 disease, poorly differentiated tumors, I think I'd be more, or perforated tumor, and there's been some time elapsed, I think I'd be more prone to do it as a separate case to evaluate.
Dr. Mayo, your thoughts on staging laparoscopy?
Yeah, I mean, even with, if we kind of look at, the Butte paper or some of the other papers that have come out looking at incidental disease that's found on re-resection, for T2 disease, about 50% of that is actually distant disease that's found, including peritoneal disease. And we know that the initial laparoscopy that's done as part of the laparoscopic cholecystectomy really isn't assessing the pericolic gutters, et cetera. So I think there's definitely a role. If the patient had spillage, has a high CA19-9, I'm probably going to book that patient for a quick 30-minute laparoscopy with washings before blocking out 4 hours to do a 4B5.
Okay. All right. So I think there's lots of, in terms of I'm going to go back a little bit. So let's say now you've done your imaging. There's no evidence of distant disease. Dr. Harufe got a PET scan as well. It just shows some SUV activity in the gallbladder fossa. There's no periaortic lymph nodes. There's no liver metastases that we can see, but it was a T2 LVI positive, PNI positive, poorly differentiated. So how would you, Dr. Mayo, how would you approach that now? And there was no gallbladder spillage at all, and it came out in a bag.
Sorry, you cut out for just a second. What was the last thing you said about the spillage? And it was
no bile spillage. Yeah, there was no bile spillage, and it actually it was removed with an entrapment sac. It was brought out.
I think in this setting, you still are at high risk for having peritoneal and regional disease. We know that from the data presented published by Dr. Pollack and also by the Memorial Group. I think the standard of care is really a 4B5 resection. I would start with a laparoscopy on the day of operation. So 4B5 resection and a portal lymphadenectomy for staging.
Okay.
And a cystic duct margin negative. So I usually routinely resect the cystic duct stump flush with the common duct, and then send that as well.
Okay. So even if the margin was negative at the original, you would still go try to dissect that out and take it flush?
Yeah, I mean, it depends. Usually it's there, it's with a clip. It's not hard to find.
Yeah. Okay. Dr. Snyder, what would you do with that T2 poorly differentiated LVI, PNI positive cystic duct margin negative?
I don't routinely re-resect the cystic duct. I think, one of the questions that I'd be curious to hear from the other panelists also is the role of lymph node sampling at the start of the operation. So I trained with Dr. Vote, who routinely samples aortic cable nodes and celiac nodes. And if those are, and sends those for frozen, if those are positive, then aborts. So I think in settings where, particularly where you think there's high risk for distant disease and you've evaluated the peritoneum and you don't see peritoneal disease or any intrahepatic disease, I think that's something that, you know, is important to consider at least. Mm-hmm. I'd be curious what the other panelists are doing about those.
Dr. Harufe, you comment on lymph node sampling starting?
Yes, we have very well standardized our radical resection or re-resection in gallbladder carcinoma. And we all the time start with laparoscopy, as I said before. And then we go straight to the group 16 lymph node. That's mean the intercava aortic lymph node. And we mobilize all the duodenum. We do a wide cohere maneuver. And then we take a sample of the 16 lymph nodes and send to frozen biopsy. If it's positive, then we stop the operation, because if you have a intercava aortic lymph node positive, then it's a metastatic disease. So it's not worth to do the whole resection. But if it's negative, we follow with all the lymph node dissection of the retropancreatic lymph node, then the whole hepatic duodenal ligament. This is the group 12. Then celiac trunk and hepatic artery. And we do routinely re-resection of the cystic duct and send the border to frozen biopsy too. And we finish the operation with a wide resection of the gallbladder bed. We don't do any more formal segment 4 and B resection. We are doing now just a wedge resection of the gallbladder fossa based on the latest publication that doesn't matter if you do bigger liver surgery. The only thing that is important in gallbladder carcinoma is to get the R0 margin.
So Dr. Mayo, do you also start off with lymph node sampling?
You know, I routinely, when I open up, I will feel, you know, like behind the head of the pancreas, like, you know, duodenum, the highest pancreatic lymph node. I'll feel the nodes along the celiac axis and up and around. If I feel something firm, then I'll often do it. But I mean, I'm thinking Dr. Harufe's, you know, very insightful comments, and that, you know, we really should, if we probably be aborting 50% of these resections, because they have regional disease, you know, if we're actually sampling the right nodes. The challenge is that, you know, there are nodes that, you know, just by, you know, palpation, we're not going to feel, or we don't know if they're positive, and we're not going to be able to sample. So I think, you know, starting with the station 16 node makes a lot of sense, and I'd actually consider, you know, incorporating it in my practice. That's a great suggestion.
And would anyone consider, so it sounds like everyone's ready to go to re-resection. Would anyone consider any other therapy prior to re-resection?
I mean, that's why I asked about lymph nodes. Certainly if he'd had a positive lymph node, then I would, you know, or even in a T3 patient. I'll also say that my patients tend to not be as healthy as maybe some of yours. So, you know, I think a lot of it also depends on their performance status and whether I feel like I need some test of time, of whether it's to do some prehab or, you know, better patient selection. But I would consider pre-op therapy in patients with node positive disease or more advanced T stage.
Okay. So let's actually get to there's lots of chat going on in terms of the extent of the 4B5. And so now let's talk about the extent of surgery. We talked a little bit about the lymph node dissection already. And we talked about staging laparoscopy. Now, extent of liver resection, we often talk about a 4B5. Is that just a wedge of the gallbladder fossa? Is it a 2-3 centimeter margin? Is it an anatomic 4B5? And when do we need to do a major hepatectomy for, again, this is for incidentally diagnosed gallbladder cancer. So Dr. Harufe, you mentioned that you used to do major hepatectomies and now you've down to the 4B5. Can you talk a little bit about the evolution of that decision-making and what your thoughts are?
Yes, because as I said before, the goal is to reach R0. So if you have a gallbladder carcinoma with mass, with preoperative diagnosis, then you have to do a big surgery, even right extended hepatectomy or whatever. But in incidental gallbladder carcinoma, like this case, which is only fine in the pathologist, from pathologists, then it's enough to do 2-3 centimeters around the gallbladder fossa. And this has been published and is part of the expert consensus that we published 4 or 5 years ago, run by the MD Anderson group.
Right. Dr. Mayo, your thoughts on the extent?
I kind of put in the chat that I tend to do a 4B5 just as I find the inflow control is a little bit better and less bloodier. When I've tried to get around just and feel that I'm actually able to get a clean depth of margin all the way around the cystic plate underneath, posterior to the plate and down, I just feel I just end up with a lot more bleeding. So I think it probably may even be faster to do a 4B5 in some ways and carving just around underneath the cystic plate.
So you actually go to the umbilical fissure and take the 4B pedicle and then find the 5 coming off the anterior pedicle?
Yeah, I would say it's kind of like, it's one of those like kind of a quote modified 4B5. I'm not going right into the fissure. I will like come like a few centimeters off the fissure, come down into and actually take that 4B pedicle as it comes in intraparenchymally. Take it and then march around, take the middle hepatic vein, and then take the 5 as it's coming up as I complete the kind of turn the corner and complete the dissection. So I wouldn't say it's a total 4B5. So maybe I'm just doing a big wedge.
Dr. Snyder, when do we need to do a major hepatectomy or a right or an extended right?
I don't think that there's indication or there's been data to support that unless there is direct invasion of the bile duct or artery. But I think that at that point, it's probably tumor biology more than the extent of doing a major hepatectomy that's going to affect the patient's long-term outcome.
Yeah, I mean, Dr. Hoof, I think the expert consensus conference does say it's only indicated for achieving an R0 resection. So as Dr. Snyder just said, if it's involving the right portal vein or the right artery that mandates a hemihepatectomy, but then there again, no distant disease, no distant lymph node disease, I think then that would be an indication for it. But for incidental gallbladder cancer, that situation happens in isolation very rarely, I think. If that situation is present, there is usually some other reason to not operate. So again, the role for major hepatectomy is usually pretty limited. And also, I just want to point out on the chat, I think people are following along, but the lymph node dissection and the issue of sending frozens, Dr. Pollack very nicely points out, when you freeze a lymph node, they basically cut it in half and look at they do one H&E slide, or maybe they take 1 or 2 depths. So very similar to how we analyze lymph nodes without really doing a detailed lymph node analysis. Sometimes you'll just miss microscopic disease in the lymph node. So I think while it's a good exercise, I think there could be a lot of false negatives potentially with the frozen section analysis. I believe that's what Dr. Pollack was getting at with his comment as he's shaking his head, yes. So we've talked about the extent of liver section and that also the bile duct. I think everyone on the panel agreed, no reason to do the bile duct resection unless you needed to achieve an R0 margin off the cystic duct. So Dr. Mayo, you had mentioned digging the cystic duct out. Let's say this patient's cystic duct margin was positive at the original resection. Would you automatically do the bile duct resection, or would you try to dissect it clean to the bile duct and get a negative margin on frozen?
Yes.
To the latter, I'm assuming.
Yeah. Yeah.
You dissect it out?
Yeah, dissect it out. And if I feel I can cleanly, get a good flush margin. I mean, there are bile duct, like cystic duct stumps, and then there are cystic duct stumps. Right. Some of them are very long and you feel good about getting a good, long, clean margin. And some are flush already with the common duct. In that latter scenario, you're more likely, I wouldn't really trust my frozen section as much. And I would probably default more towards doing an extrahepatic biliary tree resection.
Dr. Snyder, your thoughts on approaching the cystic duct margin if it was positive?
I guess if you feel like you have a long enough stump, then that's reasonable. But I think a lot of times the problem is there's a lot of fibrosis or it's difficult to tell, is this post-operative inflammation or is this potentially tumor? So I think I just would exercise caution with that.
Yeah, I just did one of these today, and trying to get the cystic duct stump out would be very difficult. It was a negative on the margin, so I didn't chase it. But yeah, Dr. Harufe?
Yes, I think it's correct, but you have a T2 or T3 incidental tumor with a perineural invasion, you have to go straight to the bile duct. It's not worth to try to get RC in the cystic duct, because probably the common bile duct will be involved also. But if it's an incidental carcinoma at T1B or not perineural invasion, then you can get longer cystic duct and negative margin. But if you're operating a T3 tumor or T2 plus perineural invasion, go straight to the bile duct.
Yeah, fair enough. So let's say you do the operation, we do the 4B5, the lymph nodes, and there is positive residual disease. The liver parenchyma is negative, but there's 2 out of 7 lymph nodes. So Dr. Snyder, now what?
So we typically are treating with adjuvant CAPE according to Bill Cap, and so that's most commonly what we use. We've also used GemCis here pretty routinely. So that's our practice.
Dr. Mayo, what do you guys do in Oregon?
Yeah, I mean, I think we individualize it and discuss the limitations of the Bill Cap trial, which, is the standard of care, in a very nice, article written by Dr. Golomé and Rachna Shroff, like in ASCO this last year. So we talk with them about, how we can apply it in patients with resected gallbladder cancer, but really all biliary tract cancer should be getting adjuvant CAPE. However, OHSU, Chuck Blank is our chair, and he's SWOG, and we accrued a lot of patients to 0809. So it's also something we consider in those gallbladder cancers with positive margins or node positive disease, which is GemCis up front, followed by chemoradiation with capecitabine. So it's something to consider and individualize. We've done it both ways.
Dr. Harufe, how do you manage in Chile adjuvantly?
Yeah, the same. We don't use radiotherapy for gallbladder carcinoma. I think it's useless. And we use chemotherapy with gemcitabine plus cisplatin in cases with lymph node positive.
Yep. And Dr. Pollack, so asking about the PRODIGE 12 results. So the GEMOX adjuvant trial, looking at GEMOX versus placebo versus the Bill Cap. And I think people have mentioned you use GemCis. I think there's not a lot of, some people use GEMOX, but I think a lot of people still use GemCis. And just with my many conversations with medical oncologists on the task force and at CTEP, I think the excitement about using CAPE and per the Bill Cap trial has subdued a little bit over the past year. And so the Gem Platinum regimen is still very much considered a very reasonable option. The radiation, I have my own personal thoughts on the radiation. The incidence of positive margins for incidental gallbladder cancer resections is less than 6%. And so I think a lot of that radiation data from the 0809 is really pertinent to the hilar cholangio situation. And I just don't know how much it really matters in incidental gallbladder, where the recurrences is usually systemic. Dr. Snyder, Dr. Harufe, do you use much radiation at all?
No radiation.
No. Dr. Snyder?
Typically just for margin positive, but
yeah, which is a pretty rare circumstance. So I'm gonna similar to Dr. Ferroni, I'm gonna take the last minute for a little bit of a selfish kind of plug here, and I kind of want to highlight the strength of the AHPBA. And I know Tim knew I was going to do this, but this is really, I think, just to kind of show the thought process a little bit about neoadjuvant therapy. And I'm going to go a little bit out of order here, but we know that the incidence of residual disease, and this is something that our esteemed president showed us many years ago, but for T2, T3 disease, which makes up 90% of the incidental gallbladder cancer that we see, the incidence of residual disease is anywhere from 50 to almost 80%. And we know patients with residual disease, almost half of them will recur in 1 year. And so I think that's a lot of the impetus for doing adjuvant therapy, but the trials in adjuvant therapy are limited. The GEMOX, the PRODIGE study was technically a negative trial, although the clinical difference was real, but the statistical difference was not. The Bill Cap trial, the clinical difference was real, and on the intent to treat analysis, the statistical difference was not. So we have, again, with the help of the AHPBA and the thought about neoadjuvant therapy, I think the rationale was reducing the incidence of residual disease, improving that resectability, that 20% of patients that we find to have distant disease at resection, improve patient selection. So, you know, Dr. Snyder was talking about if they have a lymph node positive or if the bile had spilled, maybe those are patients that we would choose for some sort of neoadjuvant approach. I would argue that a lot of these patients are at risk for recurrence, and maybe the neoadjuvant approach would improve survival if we can eradicate micrometastatic disease. So this is something that we've put together, and I want everyone to think, I know there's a lot of people on this webinar, and this was basically all these HPBA institutions that kind of came together. And just to note that this trial will be opening soon in a few weeks, and this is for incidental gallbladder cancer, and it will take the strength of the HPBA to run something like this. But it's a randomized phase 2, phase 3 trial where patients with incidental gallbladder cancer will be randomized to the control arm, which is basically re-resection up front, and then actually we'll get adjuvant Gem-Cis. So after many, many years of discussions, we've actually settled on adjuvant Gem-Cis, not adjuvant CAPE. And the other treatment arm will be a perioperative approach, very much similar to Dr. Ferroni's trial in pancreas cancer using FOLFIRINOX, but we'll be using perioperative Gem-Cis. Again, primary outcome will be overall survival. You guys will all be hearing a lot about this, but again, this will take the unity of the HPBA to kind of get this trial done, and this will be opening through the cooperative groups. So with that, at 6:32, I just want to thank my panelists. Thank you very much, and then I will turn it over to Dr. Pollock for closing remarks.
Yeah, thank you, Shishir. I can think of no better way than to close the evening than to focus on this clinical trial. I think tonight clearly demonstrated how excited we all get about treating our patients and talking about cases. And I can think of nothing more important than to do that in a rigorous prospective fashion. And I applaud Dr. Meitel and Dr. Ferroni and others for being leaders on prospective trials, and would strongly encourage folks to keep their eyes out for these trials and to be active accruers to these trials. So with that, I would like to thank all of you for joining us tonight. I would like to thank Roberto, Christina, and Shishir for moderating each session. And I'd like to thank all of our panelists. And I'd like to thank all of you for joining us tonight. And then the final and most sincere thank you I'd like to give to our management company, Margie and Jill, who worked tirelessly on behalf of the AHPBA to make these events possible. So stay safe, stay well, and stay alert. We plan on having additional webinars in the months ahead so we can remain together apart. Thank you all and have a good evening.
Thank you.
Thank you.
Thank you, Tim, for organizing.
Thank you.
Thank you. Bye, everyone.
Thanks, everybody.
Bye.
Bye.
Thank you.